cabinet. Also, there's an opacified left osteomeatal unit, but the sphenoid sinuses are clear. We also did a sagittal view of the frontal sinus, which showed a complete obstruction of the left frontal sinus with sclerotic bony expansion, and there were bony defects also in the anterior, posterior, and inferior sinus walls. Unfortunately, that video is not playing there. Oh, it's playing now. So wait, we'll see the left frontal sinus coming into view with this sclerotic, there we go. And the complete obstruction of the left frontal recess. We also did an axial view of the CT scan. It showed the ground glass appearance of the frontal and orbital bones. And there's a defect in the anterior and posterior frontal sinus table. There were no signs of cavernous sinus thrombosis. The superior ophthalmic remains were symmetrical and non-distended. There was normal symmetrical concave configuration of the cavernous sinus, and there was no filling defect of the dural venous sinuses. So I'd like to open up for any ideas on the differential diagnosis. Back to you, Matt.
Okay, thanks, Raphael. I'm just seeing who's here. Perhaps one of the others who are writing finals could give a differential diagnosis. So Tasia, I see your name comes up first amongst the participants. Would you like to contribute?
Sure, thanks, Matt. So Raphael, with that draining spinocutaneous fistula, I mean, you could think about a surrounding cellulitis getting quite deep and developing into a frontal osteomyelitis, especially if you're thinking about a chronic history that you're describing. So perhaps the frontal bone osteomyelitis could be something before, and as you mentioned, there was no previous sinus surgery or no nasal symptoms. The other thing that you want to also investigate quite keenly, and I think that was shown on the CT scan, was a chronic frontal sinusitis itself. I think those are my top two differentials, Matt.
Thank you very much, Tasia. Raphael, do you agree?
Yes, I do agree, yes. So that's what we thought about. We thought the top one was the left chronic frontal osteitis, the secondary to a chronic rhinosinusitis without nasal polyps. But we also thought, because of the bony changes, we also thought maybe there's a possibility it could be fibrous dysplasia or Paget's disease. We also thought of infections, like TB or sarcoidosis, and also neoplasia, hematological, very rare in the frontal sinus. And also we thought it could be sinonasal tumors, also very rare in the frontal sinus. So the management of the patient, we prepared the patient and took the patient to theater for a left combined frontal sinus drainage procedure. We commenced with a Lynch-Howarth incision and included the fistula tract in the incision. Our findings were a large anterior table defect as per CT scan, and there was pus in the frontal sinus. There was pus in both maxillary sinuses, and there was diseased bone in the left frontal sinus. So the procedure is we dissected down to the bone and chiseled a diseased bone away. We scraped off the frontal sinus mucosa and did an external frontal ethmoidectomy and left the lamina intact. We did a bilateral antral washout and a left uncinectomy, meatal antrostomy, and anterior ethmoidectomy on the left side. The meatal cabinet was sacrificed and we left a stump. The frontal recess was assessed by a combined procedure. We used a draft 2A procedure with an above with an external approach, and below we used a frontal sinus curette. We left a corrugated drain as a stent, and we closed the wound in 2 layers. The lab results came back. The histology showed subacute inflammation, and the pus swab showed neutrophils and no growth. So postoperatively, we ask the patient to use nasal steroids and to use nasal breathing so as to prevent any formation of any obstruction. So I thought we could talk about chronic frontal sinusitis. So frontal sinusitis, it can be because of a blockage of a frontal recess by chronic rhinosinusitis with or without nasal polyps. The blocked frontal recess predisposes to chronic frontal sinusitis and also a failure of medical therapy. However, there is no agreed clear etiology of this condition. Just a bit of anatomy. At birth, it's a small blind pocket, and there's a radiological identification by age. Pneumatization starts early in adolescence and continues until the age of 8. The frontal sinus reaches the adult size ratios by age 10 to 12 and drains into the frontal recess. The frontal recess, where the frontal sinus drains to, is actually an hourglass structure. It has complex anatomical relations. Anteriorly, there's the Aganassi cell and the frontal beak, and posteriorly, there's the anterior face of the bulla. Medially, you find the superior attachment of the medial turbinate and the lateral lamella of the cribriform plate. Laterally, there's the lamina papyracea. This is a diagram of a coronal section showing the uncinate process in the red line. So the uncinate process is a crescent-shaped bone which is attached inferiorly to the inferior turbinate. Its superior attachments can vary from medial turbinate to skull base to lamina papyracea as depicted here in the diagram, or a combination of these, which actually is the common attachment. If present, the Aganassi cell is intimately related to the uncinate process, and Aganassi is present in more than 90% of patients. There is a complex arrangement of cells around the frontal recess, which are classified as anterior, posterior, medial, or lateral, depending on their relation to the frontal recess, and they can obstruct the frontal sinus ventilation if they are large. So the classification of the anterior ones, you find the Aganassi, which is described as a cell that sits anterior to or directly above the origin of the medial turbinate. So the significance of all these anterior cells is that they tend to push the drainage of the frontal recess posteriorly. We also get the frontal ethmoidal cells, which are anterior lateral ethmoid cells, which sit above the Aganassi cell. And they are anterior. You can distinguish them from the posterior ones because they are in contact with the frontal process of the maxilla, the frontal peak. So they are classified into 4 types. You get a type 1, which is a single cell that sits above the Aganassi cell, called the supra-Aga cell. And you find a type 2, which are a tier of cells that sit above the Aganassi cell, but they don't enter the frontal sinus. Then you get a type 3 and type 4. Type 3 and 4, these are cells that enter the frontal sinus to varying degrees. The type 3 will be a cell that pneumatizes into the frontal sinus and is called a supra-Aga frontal cell. The type 4 cell is the one that it pneumatizes into the frontal sinus and extends by more than 50% of the vertical height of the sinus. This is the diagram that shows the cells I just described. You can see it's a T1, it's a type 1 cell, and you can see 2 type 2 cells on B, and then you can see a type 3 cell, which is getting into the frontal sinus, and then a type 4 cell that is going into the frontal sinus and is more than 50% of the height of the frontal sinus. So those are the anterior ones. And then when you come to posterior ones, you get the suprabular cells. The suprabular cell, which is a cell that is above the bulla but doesn't pneumatize into the frontal sinus. And then you can also get a frontal bulla or suprabular frontal cell, which is a cell that pneumatizes forward from the bulla or suprabular space. And then there's the supraorbital ethmoid cell, which is a pneumatization of the orbital plate of the frontal bone. And so these cells, they tend to push the frontal sinus drainage anteriorly because they are posterior. And then you get a medial cell, which is the intersinus or frontal septal cell, which is quite rare. This is a cell that's placed medially in the anterior ethmoid region or pneumatizing into the interfrontal sinus septum, and it tends to push the drainage of the frontal recess laterally. So this is a diagram of the frontal bulla cell. As you can see, it's pneumatizing forward from the bulla, and it's not in contact with the frontal process of the maxilla, which is marked with an asterisk. And that red arrow is the drainage pathway of the frontal recess. This is a CT scan of one of our patients we recently had. It shows a supraorbital ethmoid cell, which is pneumatization, showing pneumatization of the orbital plate of the frontal bone and producing a double laminar effect of the orbital roof. Now, the concern about this type of a cell is that it leaves the anterior ethmoidal artery hanging by mesentery, and thereby endangering it if you are doing endoscopic sinus work. So when we evaluate a patient with suspected chronic frontal sinusitis, or any patient with a rhinosinusitis, there's a criteria that we use from the European position paper on rhinosinusitis and nasal polyps. The diagnostic criteria are the patient should have primary symptoms. You require at least one of it to be present. And that is nasal blockage, nasal obstruction, nasal congestion, or discharge, which can be anterior or posterior. And then you also have to ask about additional symptoms, which may also be present, and at least one is needed. If only one of the primary symptoms is present, then you need at least one of these, which is facial pain or pressure. So our patient did have a facial pain for about 2 years, and olfactory dysfunction like hyposmia or anosmia. And the duration is used to classify it into acute or chronic. So our patient had this for more than 3 months. So that's why it was a chronic condition. And one of the diagnostic criteria is endoscopic findings. One can either find nasal polyps or mucopurulent discharge from the mealy meatus, or edema and mucosal obstruction. And characteristic CT scan findings, you need at least endoscopic or any one of these. If you don't find any endoscopic findings, at least the CT scan findings also count. And these are mucosal changes within the osteomeatal complex and or sinuses, which our patient had. So when we evaluate this patient, it's important to also ask about a facial trauma, a previous sinonasal surgery, or asthma and aspirin sensitivity, and any dental caries, because you can get a sinusitis of odontogenic origin. A CT scan is the gold standard investigation. You can do coronal, axial, and parasagittal views, as we did. The coronal views are the most frequently used because they've got a better correlation with findings during surgery. But one can also use sagittal views to show the drainage pathways and identify complex cells. Axial views are also useful, especially if you're going to use a navigation, which we did with our patient. There are some associations with a chronic frontal sinusitis. These are not causes, but associations. Posterior cells which are posterior to the frontal recess, like the suprabular cells and frontal bular cells and supraorbital ethmoid cells, have been found to be associated with a chronic frontal sinusitis. And those which are anterior to the frontal recess, like the Aganassi cells and the frontal cell types 1 to 3. Also, uncinate process attachment to the laminar papyracea in this study, it was found to be associated with frontal sinusitis. Though what they did was they looked at the patient who had chronic frontal sinusitis and discovered that in the majority of them, the uncinate process was attached to the laminar papyracea. But my question is, we don't know what the prevalence is in the general population of the uncinate process attaching to the laminar papyracea. So I think it will be difficult to draw that conclusion, but it is out there in the literature. And also inflammatory mucosal disease. So in terms of the surgery, this is a complicated disease to manage chronic frontal sinusitis because of the variable anatomy, as we have seen, which obstructs the frontal recess. However, the principle is that the frontal recess mucosa must be preserved, and postoperative care is very important so that we maintain the patency of the frontal recess. Otherwise, you get the patient coming again with obstruction and subsequent frontal sinus pathology. So like most of medicine, before we operate on these patients, you look at the patient factors, you consider patient factors, anatomical factors, and pathological factors. On the patient factors, you look at compliance issues and significant comorbidities. If there are issues like that, then you have to do a simple phase with minimal manipulation of the frontal recess. Also, patients with asthma or aspirin sensitivity, these ones, they tend to do poorly. So you want to do a comprehensive clearance of the frontal recess. You also look at the anatomy, whether the landmarks are preserved and whether they've had any previous surgery, or if they've had minimal previous surgery and there are no complex cells, then one can go ahead and do a draft type 1 procedure. But if there are poor landmarks with osteogenesis and multiple revision procedures, a thick frontal peak and complex frontal cells, one is to be more aggressive and do a draft type 3. I think it should be a draft type 3, which is a modified endoscopic Lothrop. In terms of the pathology, if you get chronic frontal sinusitis with or without polyps and no previous surgery, a draft type 1 should be sufficient. If there is recurrent disease with polyps and eosinophilic mucin, chronic rhinosinusitis or tumors, lateral mucocils, or recalcitrant chronic sinusitis, then one can consider doing a draft type 3, be more aggressive, and do a modified endoscopic Lothrop. And a complicated frontal sinusitis with erosion of the posterior table, with anterior table osteitis and tumors extending laterally, then one can also consider doing a draft 3. So the approach is graduated from a simple, which is a balloon sinuplasty, through draft 1, draft 2A, and draft 2B, and draft type 3, which is also known as the modified endoscopic Lothrop, also known as the frontal sinus drill out. One can also do an osteoplastic flap and a modified endoscopic Lothrop and a Rhidel's procedure, and finally a cranialization. I will go through this one by one. So a balloon dilation is a minimally invasive approach for chronic rhinosinusitis involving the frontal sinus. It affects microfractures and compression of a soft tissue, and it is never done in isolation, but as a combined procedure with endoscopic sinus surgery, in which case it is called a hybrid procedure. A draft type 1 involves removing cells within the frontal recess following a phase. It is the commonest procedure done for chronic frontal sinusitis. It clears the obstruction below the frontal ostium. One has to do a complete ethmoidectomy, remove the anterior superior ethmoid cells, the Aganassi cell, and the uncinate process, and it is sufficient for minor frontal sinus disease. The draft type 2 frontal sinusotomy is indicated where conservative surgical approach has failed. And this involves a removal of cells which are extending into the frontal sinus. It involves widening of the frontal ostium from the lamina papyracea. If you widen it from the frontal ostium to the medial turbinate, then it's called a draft 2A. And then if you widen it from the frontal ostium from the lamina papyracea to the nasal septum, then it's a draft 2B. A draft type 3, which is also known as the modified endoscopic Lothrop or median drainage procedure or frontal sinus drill out, was first described by Lothrop in 1914, and it has become more popular as an alternative to frontal sinus obliteration. One is to start with a complete sphenoethmoidectomy. This creates a large common frontal sinus drainage pathway by resecting the upper nasal septum, the frontal intersinus septum, and the floor of both frontal sinuses. These are the CT images of a completed draft 3. Mini frontal trephines for frontal ostium identification can be used as an adjunct. And also one can use computer-assisted navigation, which we used in our patient. However, this is not a substitute for good anatomical and sound knowledge of the surgical procedure. So in addition to refractory chronic rhinosinusitis, one can also use the modified endoscopic Lothrop for repair of lateral CSF leaks, like in frontal sinus trauma. And you can also use as an alternative to osteoplastic flap with obliteration, as we shall see right now. And you can also use the same procedure to access tumors like inverted papilloma or frontal osteoma, and as a part of scalp-based resection for anterior cranial fossa tumors, or even for excision of, for example, large mucocils. The osteoplastic flap with or without obliteration involves an above, which is an osteoplastic approach, and below, which is endoscopic approach. It involves removal of all mucosa within the sinus. One can use or not use obliteration with fat. It is used for chronic frontal disease that is refractory to other procedures. However, this procedure tends to leave a deformity called a step deformity. And so one can actually do a flap with it. The relative indications for an osteoplastic flap procedure are access to tumors, extensive frontal bone osteomyelitis, and extensive neoosteogenesis of the frontal recess, and frontal sinus fractures with CSF leaks. Enrich's procedure involves removing the floor, anterior wall, and mucosal lining of the frontal sinus and is rarely performed. It is indicated where there's drainage, where drainage cannot be established, and also where frontal sinus obliteration has failed. And in osteomyelitis or in frontal sinus anterior wall tumors, one can use a pedicled pericranial or gallial soft tissue flap to reduce the cosmetic deformity postoperatively. Finally, cranialization involves removal of the sinus mucosa and posterior table of the frontal sinus, and it is the final surgical measure. It is the removal, it's basically removal of the frontal sinus and is used for refractory chronic frontal sinusitis. It is rarely performed and its indications are osteomyelitis, tumors, and frontal sinus fractures. Thank you very much.
Thank you very much, Raphael, for an excellent, very comprehensive talk on the approaches to the frontal sinus. I think we'll just start by asking Professor Libbe if she'd like to make any comments.
Thank you, Matthew. Thanks, Raphael. It was a good presentation. Maybe we can just start with that scan, the coronal scan. And then the important thing is to decide, you know, in this patient, if you accept that it is a chronic frontal sinusitis, you know, what are the management options? And the management options really depend on, you know, the what instruments you have available, your experience. But there's some specific things that you have to look at. So I wonder if you can put that coronal up for us. And so here we did an external frontal ethmoidectomy, which I must say is probably the first time in many years, probably more than 5 years, that I've done an external kind of procedure like that. And the reason is one, you have to try and ventilate and communicate that frontal sinus with the nasal cavity. If you're unable to do that, you're going to get recurrent disease. So in this case, if we did an endoscopic Lothrop, you know, there was very, very thick bone that you had to go through. So if we can just see that coronal slide, Raphael.
Yes, I'm trying to share. It's taking some bit of time, but
yeah, so with the Lothrop, you have to think, first of all, have you got the instrumentation to get to that area? So have you got the 70-degree drills? You know, you cannot get around that corner of the frontal recess into the frontal sinus just with a straight drill bit doing it endonasally. So if you haven't got the right equipment, then you have to look at another procedure. The other thing is, even if you have the right equipment, you know, how much time do you have? You know, we know that in Africa, you know, more so than in the first world countries, we really have a problem with our theatre time. And it might take us 3-4 hours to drill out that sinus, where if you do an external approach, you know, you can do that with under an hour. So just show us the frontal sinus. Just stop at the initial kind of slice. Okay. So go a little bit further back. Yeah, so stop one further back. So you can see that tremendous thick bone. So if you look at a patient, you know, when are they candidates for endoscopic Lothrop? You want to look at, you know, is there one frontal sinus, both frontal sinuses? Because by definition with the Lothrop, you communicate your left and your right side. And in this case, the patient only really has a left-sided frontal sinus, so you can't really do a lothrop. And then you're going to look at the sagittal and see, and you really want about 1.5 centimeter anterior posterior diameter to be able to do a drill out. So in this case, I felt that that was not going to be possible. Secondly, if you then do an external procedure, which we've decided to do in this case, you have to decide, are you going to try and communicate that frontal sinus with the nasal cavity, which is first prize, or are you going to, it doesn't help if you just drain that collection. So you really need to, if you're going to obliterate it, be able to remove all of the mucosa from that sinus to obliterate it with fat. So that's also, and that's an easy procedure to do, you know, with very limited kind of skills and instrumentation. Where you do a Lynch-Howarth incision, you get access with or without an endoscope, you can scrape out all that mucosa. What the difficulty there is if you put fat into that cavity and that patient presents with headaches later on and you rescan that patient, you're always going to have a pacification of that frontal sinus. So it becomes very difficult to evaluate whether the headaches are due to a sinusitis. And the only way to tell is actually then to do an MRI scan to distinguish between fat and infection, or to open up that area. So I've moved away from obliteration for that reason. So what we did here is an external frontoethmoidectomy, but I would say modified by leaving the lamina papyracea intact. And the reason we do that is one of the biggest reasons for mucocele formation in your frontal sinus is the old-fashioned frontoethmoidectomy. And what happens if you remove that lamina papyracea, you have the periorbiter and the orbit prolapsing or collapsing into that frontal recess and obstructing it. So that's why you want to keep that lamina papyracea superiorly intact if you can. So we did a drill out with a straight drill, because that was all that we had available at this case, from above and into the nasal cavity. And then I don't know if you've shown us surgical videos of this patient. I don't think you showed us anything, Raphael, but we actually did a combined open and endoscopic where we worked through the nose and from above. And so that's also an option to do that. Then obviously the cranialization and the osteoplastic flap you spoke about, and usually you would ask your neurosurgical colleagues to help with that. Maybe we can see if there are any questions from the audience.
Thank you very much, Professor Libbe. As it stands, there are no questions, but just one question, which is always a debate, and I'd like to know your opinion on. Essentially, a case like this has an underlying osteitis by definition. What, in terms of duration of antibiotics, what do you recommend and what do you routinely do for your patients with such a picture?
Yeah, it might be dangerous to say it on this platform, but I really don't believe that you get a sinus osteomyelitis similar by definition like you get in orthopedic kind of the long bones. You know, we treat those patients for months and months. I've really never seen a patient where I've had to treat them long-term on antibiotics, talking about weeks or even longer because of osteomyelitis. So, you know, with these cases, I think it's important to drill away some of that bone and remove the mucosa. But I don't think it's the actual bone that's infected. So I don't think there's a place for longer than 2 weeks of antibiotics looking at specifically your culture. So, you know, so we know that clindamycin and these things are, it's got better bone penetration, but you really want to know that what the organism you're dealing with. So, so I would always just give a maximum of 2 weeks, or if the patient is sensitive to azithromycin, I would give a 6 weeks course of azithromycin, where you start off with 500 milligrams a day for 3 days, and then you go onto half dose. So 250 milligrams Monday, Wednesday, Friday. And that you can continue for 6 weeks and 3 months. But that's usually more those patients with chronic inflammation, and you're using it for the anti-inflammatory and the immunomodulatory effect, and not just the antibiotic effect.
Thank you very much.
So much. I do have a question also. Yeah.
Okay. Go for it, Raphael.
Yeah. Prof, when we did the CT scan pre-operatively, we thought it showed like a posterior defect in the frontal sinus table. But then intraoperatively, we couldn't appreciate that there was a defect. But however, if, for example, this patient did have a large defect posteriorly, would we have gone ahead and done cranialization? How would we have proceeded?
So, so it doesn't matter if there's a defect. It matters if there's a defect and you cause a CSF leak. So, if you appreciate, so often the scans over interprets pathology. So it looks like there's no bone, but when you actually get there at surgery, there will be a very, very thin sliver of bone. It's the same with the laminar papyracea. Often it looks like it's dehiscent, but you can see it's very paper thin. So the important thing is just to know where there is a defect, a potential defect, so that you don't injure the dura. But you must remember that you will not get a patient, there's no higher likelihood of getting meningitis if you've got intact dura. We often, with our endoscopic resections, I would resect bone and you go onto dura, and you don't try and reconstruct that area, it re-epithelializes. So those patients aren't more at risk for meningitis. The only risk is if there's a leak. So I wouldn't try and attempt to reconstruct it or cover it. As long as you've got ventilation to the nasal cavity and that sinus can aerate, you're not going to have a problem with that. So I think that answers your question.
Yes, thank you.
Thank you very much. Prof. Liver, there's just one question. What post-operative medication do you use in such a case?
So for this case, we would obviously always use an intraoperative antibiotic, and then I would wait for the culture. So because these patients have been on so many antibiotics, I don't routinely give them antibiotics post-op. I'll wait the 40 hours for the culture result, and then I'll guide it according to that. So once again, if it was sensitive to zithromycin, I would have given 6 weeks. Otherwise, if it's sensitive to just co-amoxiclavulanic acid, I would have probably just given 10 days, which I think we did in this case. But no steroids. So there's only a place for steroids if you have a patient with nasal polyposis. In my view, there's no place if you have an infection like this to put those patients on post-operative steroids. You want to stay away from steroids in these infected cases. And then obviously the topical douching. In this patient, we did actually place a stent, which we removed after 3 days. And the reason for the stent is you have circumferential kind of injury where we drilled into the nasal cavity in the frontal ethmoidectomy kind of a pathway, drainage pathway. And you just want that to re-epithelialize a little bit and get rid of the infection. Similar to mucocele formation, you can create a very wide cavity for mucocele drainage, but because of the inflammation, you often get stenosis. So I like to put a stent just for a couple of days, just so the patient can douche into that area. So your douching is very important.
Thank you very much. I think in interest of time, we'll move on to our next case discussion. So I'd like to invite Dr. Brownell, also from the University of Cape Town, to please share her screen and proceed with her case discussion.
Morning, Matt. Morning, everyone. I'm just sharing the screen. Matt, can you see the screen?
Yes, we can. Thanks, Louisa.
Okay. Good morning, everyone. My name is Dr. Brownell. I'm a UCT registrar at the University of Cape Town. Our topics this morning are rhinology, and there's just one case from the ward that I thought we could talk about. Sorry, just make sure I don't know. Okay, so we've got consent from the patient, no copyright infringement is intended, and the presentation is for teaching and training purposes. Our case presentation today is a gentleman, Mr. S. He is a 47-year-old male. He was HIV unknown, and he was also a newly diagnosed diabetic patient. There was quite a difficult history from this gentleman due to a significant language barrier. He's not from South Africa. But in essence, he presented to our emergency unit, to our ophthalmology departments initially with a 5-day history of initially painless loss of vision in his right eye, and then some very vague nasal symptoms in the form of mild nasal obstruction and a little bit of rhinorrhea. And at the time when we saw him, he was awake and alert. We did anti-rhinoscopy and didn't really reveal much, couldn't see any pus or masses, no overt nasal discharge. At that point, he was COVID unknown, and the flexiscope was deferred at that point. His oral cavity was completely clear, and on examination of his right eye, it was noted that he clearly had proptosis. He had ophthalmoplegia in the form of a fixed globe with very minimal movement. At this point, he had absolutely no light perception in that right eye, but there was no hemosis. But on oral examination, it was also noted to have some dental caries. There was a bit of a delay with regards to his COVID testing, around about 24-hour delay, but his COVID test did eventually come back as negative. But due to the dental extractions, we were quite concerned, and we also got max fax to evaluate the patient to establish whether or not there was a dental source of infection that was causing some of his symptoms and signs. At this point, he had been referred to us by the ophthalmology team, and he already had a CT scan. The scan was an orbital scan rather than a sinus scan, but in the image on the right, there is some things that I thought might be useful to look at. On the CT scan, it showed the right eye was proptosed with a bit of fat stranding, and there was this rim-enhancing subperiosteal collection that was abutting that orbital floor, and the collection actually displaced the inferior rectus and inferior oblique muscles. There was also some increased enhancement of that inferior rectus. They noted that there was a froth-like appearance in the sphenoid sinuses, of which I'll show you an image in a few minutes. But there was no superior ophthalmic vein hyperdensity and no intracranial extension seen. And at this point, we were a bit concerned that perhaps this was an acute complicated sinusitis with an infratemporal and an orbital collection. So in the image on the right, you can appreciate that there is a small infraorbital rim enhancing collection on that right eye. And it also gives you the impression that there might be a bit of proptosis, even though this is only one slice image. So of other notes on this gentleman's CT scan is he also had this periantral fat stranding that you can see in the right image when you compare it to the left. And then there's also some further fat stranding in the image on the right, sort of pre-antrally. With regards to the sphenoiditis features that they were talking about, the bubbles, you can see quite clearly in that CT image on the left, you can see that there's that bubble appearance in the sphenoid sinuses to suggest that maybe this man had a sphenoiditis. And on the right eye, he had this possible proptosis, which was fairly mild according to the measurements, but certainly you get the impression that there is some right eye proptosis. So at this point, we started in broad spectrum antibiotics in case this was an acute acute bacterial sinusitis. We started him on an insulin sliding scale, and we booked him for theatre. We wanted to open up bilateral sphenoids and have a look to see what we could find and clear out some of the pus, and also address the infratemporal and orbital abscess drainage at the same setting. Intraoperatively, which was endoscopically, he actually had features that suggested that this was more likely to be an acute invasive mucormycosis. There was quite a bit of involvement of his right inferior turbinate, the right middle turbinate, which is quite common in mucor, the frontal recess, infratemporal fossa, and the inferior orbit. And we also required doing frontosphenoethmoidectomy for him. At this index surgery, we removed the posterior wall of the maxillary sinus endoscopically, and we entered the pterygopalatine fossa and infratemporal fossa, at which point we also found pus. We removed a portion of the roof of the maxillary sinus and also found a little bit of pus coming from that orbital floor. On this basis, we didn't have culture results as yet, so we started empiric ampho B, and he was also in the ward put on intranasal corticosteroids. We quickly got consults to infectious diseases and endocrine team, and we sent off our intraoperative specimens for culture and histology, which actually confirmed that this gentleman did have mucormycosis. But after this index surgery, he had these intermittent, ongoing low-grade temperature spikes, very slow improvement in his visual acuity, mild ongoing headaches, and a glycemic control average of around 12. At this point, he was COVID negative, and we did do an F&E around about 12 hours after his index surgery. There's only a little bit of an area of blood clot, but otherwise it actually appeared fairly clear. However, we knew, this being mucor, that we should have a very low threshold for rescan and subsequent relux surgeries. And while this gentleman was on the ward, he actually had a total of 4 relux surgeries and 3 CT scans. At the relux surgeries, there was quite a bit of debridement of necrotic bone, endoscopic approaches, and this gentleman essentially had a needle maxillectomy. At one point at our third relook, we were even concerned about a possible small oroantral fistula, which we repaired intraoperatively with a nasoseptal flap. So more than a month later, this gentleman being in hospital with significant electrolyte derangements that required ongoing management, having repeat COVID testing just to make sure that he was in fact COVID negative, the gentleman was discharged. This is the image, just one image after our first relook. So you can see that we've addressed the right aspect of the sinus. We've taken down some bone. We've addressed those turbinates. We've done a frontoethmoidectomy as well as sphenoidotomy. And on the CT scan, I mean, it appears fairly clear at this point. Some of the other things that we accounted with this gentleman is, just to give you an idea in the image on the left, we were a bit concerned about an oroantral fistula by the secondary look. And perhaps on this image, you might appreciate that maybe there's a small breach in that maxillary sinus floor. On other imaging, the laminar papyritia is notoriously very thin. But when we went back the second time, we also thought that perhaps maybe even that laminar papyritia has got some bony erosion on the right. This is an image of his proptosis before surgery by the measurements. So you can see that you do definitely get the impression that eye was proptotic. And the image on the right shows that his proptosis actually improved. And this was after his secondary look. So he was finally discharged home once clinical and endoscopic resolution was achieved after more than a month-long hospital admission. By discharge, he was able to count fingers. He knew how to administer his insulin therapy, and he's currently due for follow-up. So really, I wanted us to talk about fungal disease of the paranasal sinuses. So in essence, it affects the paranasal sinuses by this inhalation of spores. And then the spectrum of disease depends very largely on how immunocompetent the host is after the inhalation of spores. It's broadly divided into 2 categories. It can be either subdivided according to duration. So as Raphael mentioned, it can either be acute or chronic, acute being less than 4 weeks and chronic being more than 4 weeks. Or it can be subdivided into invasive or non-invasive. So with regards to fungal disease of the paranasal sinuses, we've got non-invasive groups and invasive groups, so a total of 5 groups. The non-invasive ones are generally your fungal balls and your allergic fungal sinusitis. And this is really where you only have colonization on the surface epitheliums of tissues rather than actual deep invasion. If we look at the invasive group, and specifically we are looking at acute invasive fungal sinusitis today, that's where you have these fungal hyphae that are actually within the mucosa, the submucosa, bones, nerves, and of course blood vessels. This is a table that's taken from Scott Brown. What I'd like to highlight is, obviously you can see your non-invasive groups and your invasive groups on the right. The important thing, the thing that sort of sets acute invasive fungal sinusitis apart from the other types of fungal sinusitis, although you can have aspergillus as a species, with acute invasive fungal sinusitis, we get mucormycosis, which you don't really get in the other forms of fungal sinusitis. The other important thing is that the immune status of the host in acute invasive fungal sinusitis is immunocompromised. In a lot of the other fungal sinusitis, you can actually have fungal sinusitis in immunocompetent patients, but certainly with the invasive fungal sinusitis, it's the group of immunocompromised patients. We'll look a little bit at some CT findings later on. And with regards to treatment, you know, with acute invasive fungal sinusitis, there's a very important component in addressing these patients, and that is actually trying to reverse that underlying immunocompromised state, as well as surgical and obviously antifungal therapy. So it's quite a rare but very rapidly progressive disease, and it can be fatal within days. It's by far the most lethal form of fungal sinusitis, and mortality rates are quoted of up to 50%. The common organisms are Aspergillus or the Zygomycetes group, especially mucor and rhizopas. And you have to have a very high degree of clinical suspicion in these patients. Once there's that inhalation of spores, these fungi grow and they then begin with the invasion into the neural and vascular structures. And when they go into the vessels, they have this vessel thrombosis, which results in mucosal necrosis. It, of course, can then extend beyond the sinus, and this is done by either bony erosion, perineural, or perivascular invasion. So histological features, just to demonstrate this angioinvasion, you get mycotic infiltration of blood vessels. This creates a vasculitis with thrombosis, resulting in tissue infarction and hemorrhage, and you also get quite a neutrophilic infiltrate apparent on histology. The common organisms, if we compare the two organisms, the one is Aspergillus and the other one is mucor. So Aspergillus histologically has much thinner hyphae than mucor, and it's got these very regular septations, and they branch off about 45-degree angles, whereas in your mucor, you have very broad hyphae with very few or no septations, and they tend to branch a lot more irregularly and sometimes at a 90-degree angle rather than a 45-degree angle. There are some predisposing factors for mucor. So by far, the largest group are your diabetic patients, such as our patient, and this is especially prevalent if they've got a ketoacidotic state. If it occurs in diabetics, the most common organisms is mucor and rhizopas, and this is because they actually have an active keto-reductase system, so they can thrive in these very high glucose and very acidotic environments. The other big group that will predispose you to developing mucor are your immunocompromised patients, and here your Aspergillus is actually more common than the mucor and rhizopas. So in your immunocompromised patients, these are the patients that are very severely neutropenic, your hematological malignancies, such as acute leukemia, chemotherapy patients, bone transplant, and even AIDS patients. And then there's a third group of iron overloaded patients, which also may develop a form of mucormycosis. So presentation and symptoms can be challenging because there's this inadequate host immune response. It makes the diagnosis very difficult. So you've got to have a very high index of suspicion in any immunocompromised patient, especially those presenting with localizing sinonasal symptoms. Symptoms patient might report are fever, cough, epistaxis with a bit of nasal crusting, ongoing headaches, blurred or double vision as in our patient, and then they can have this facial pain or numbness and facial swelling on the same side. Some patients even complain of palatal numbness. So if we look at the clinical features from Scott Brown says that the hallmark is really febrile neutropenia and facial pain with or without nasal congestion and orbital signs. These signs and symptoms develop very rapidly within a couple of hours. And if we look at the orbit, you can have proptosis, loss of vision as in our patient with diplopia. Orbital signs are quite common presentations of mucormycosis. They can occur in around 50% of patients according to Turner et al. And then, of course, you have the nasal presentations like crusting, ulceration, granulation tissue, and mucosal discoloration. And the crusting and granulation can involve either your inferior turbinate or your middle turbinate. And you get this Eshkar formation, as you can see in this image. If it extends to the cavernous sinus, you can have perennial nerve palsies of 3, 4, and 6, and with subsequent diplomoplegia and orbital pain. If there's thrombosis of the carotid artery in that cavernous sinus and there's extension to the circle of Willis, you inevitably will have cerebral or brainstem infarctions. And if there's any intracranial extent, you'll have headaches, neurological deficits, seizures, comas, and up to about a fifth of patients present with altered mental status. What's important to know is that patients can actually present with very advanced intracranial and orbital complications with very few signs of rhinosinusitis, and your nase endoscopy can actually be normal. So you have to have a very high degree of suspicion in any patients with orbital or cerebral signs. Those are with or without evidence of sinus disease. And it may be worth rescoping or scoping these patients 6 to 12 hours later, even if your initial scope was normal, just to check that there's been no evolution of disease. So how do we make the diagnosis? Well, there's an endoscopic role to play, which in our setting was a little bit delayed because we didn't have, it was COVID era, we didn't have a COVID test for almost 24 hours. But endoscopically, it might be very subtle. And usually your middle turbinate is classically involved, and this is where the aeroallergen disposition is thought to occur. But there can also be palatal, inferior turbinate, and lateral wall involvement. They can also describe paresthesia or reduced sensation in the nose. So when you see the mucosa, one of the most consistent physical findings is that change in mucosal appearance. So you can have either pale mucosa, necrotic tissue with black crusting, that's when you have that angioinvasion, or sloughing. This can involve the nose and the septum, and you might even have a septal perforation. So when you want to do when you want to make the diagnosis, you have to do multiple biopsies. You want to biopsy that middle turbinate especially, and especially the nasal septum. And the purpose of the biopsy is obviously to make the diagnosis and also to get an organism so you can direct your therapy. The gold standard of making a diagnosis is really pathological examination of your sections. And they can use various features to identify invasive features, and they can also distinguish your mucorales species from aspergillus. But this is quite time consuming, and if you rely purely on this, there may be a delay in starting treatment. So we need a better solution. And in this regard, frozen section might be the quickest way. At least it can tell you whether or not there is rapid evidence of invasion. So frozen section has a sensitivity of around 84% and a specificity of 100% compared to the gold standard. And then lastly, obviously you want culture. So this is important to determine your species. You want to have a look at your sensitivity of your antifungal agents. But even if we culture it, the sensitivity for culture is only around 54%. So really, I suppose we have to be able to put our clinical judgment, history, as well as the gold standard, which might take some time to get the result back. And we might need a combination of all these things in order to treat our patients adequately. There is, the literature does talk about serum PCR and galactomannan or beta-D-glucan. And these, in essence, are components of that aspergillus cell wall. So it can be useful if it's available. If both these are negative, the negative predictive value is up to 100%. If they are both positive, the positive predictive value is around 88%. And individually, each have a sensitivity and specificity of around 80% in detecting invasive aspergillosis from all body sites. So that might be something that you can consider using if you have available. We don't have it available at our center. The other very important aspect we've kind of touched on, but we'll look at a bit more, is CT and MRI findings. So if we compare invasive fungal sinusitis to allergic fungal rhinosinusitis, we find that invasive tends to have more focal bony erosions. It lacks that expansile sinus impression. There's more limited sinal disease evident, but there can be more disease outside of the sinuses than within when you have that intraorbital or intracranial extension being present. On MRI, if you do a post-contrast to T1, you might also see hypointense areas due to angioinvasion. So if we look at CT, CT is good for showing us bony destruction. You might end up having something like a non-contrasted CT. Sometimes the patients are too unwell to be able to have a contrasted CT. And then you might see hyperattenuating mucosal thickening in the nasal sinuses, bony erosions, and thickening of periantral flat planes, which I'll show a picture of in a few minutes. If you look at MRI, this is much better for mucosal and infraorbital intracranial involvement. It's much more superior at detecting extrasinal disease. It can pick up early orbital changes, such as inflammatory changes in the orbital fat. You can see leptomeningeal enhancement when there's cerebral involvement. You can obviously see your abscesses, and you might even get an impression of areas of infarction or subarachnoid hemorrhages. So this was quite a good paper by E.H. Middlebrooks, and in essence, they had a look at a comprehensive update of CT findings. And they've sort of, in the left column, you'll see that they've listed all the CT findings you might have, and they've actually demonstrated their specificity and sensitivity. So just with regards to going through some of these, The periantral fat is the one at the top of the list. And then you can also have things like your pterygopalatine fossa, nasolacrimal duct involvement, lacrimal sac. And in these images, there's 4 of them. These are images that are established, these are patients that have established findings in invasive fungal rhinosinusitis. So in image A, there's an axial image which shows unilateral mucosal thickening, and it involves that right maxillary sinus that's sort of indicated by the asterisk. And then there's some soft tissue infiltration in the right anterior periantral fat. So you can see that in picture A by means of the arrow. And then you also have this posterior periantral fat, which is demonstrated by that small little arrowhead. In image B, just one over to the right, that's an axial image. This is now a different patient. And it shows unilateral right nasal cavity involvement indicated by that little white asterisk. And also the maxillary sinus involvement, that's your black asterisk, as well as involvement of that right posterior periantral fat. So you can see that little white arrow there. If we move down to image C, this is a coronal CT in again a different patient, and that illustrates orbital involvement with very subtle infiltration of the right medial and inferior extraconal orbital fat, and that's indicated by all those multiple little arrowheads. And in that image, there's actually no bony erosion, even though there is that orbital fat involvement. And then lastly, in image D, that's also an axial, it shows a very subtle ulceration along the left side of that nasal septum, indicated with the arrowhead as visible in that image. Just a few more examples. So in image A and B, there's an axial post-contrast CT images, and they show filling defect in the right cavernous sinus. So you can see that little white arrowhead with adjacent parenchymal hyperattenuation. There's also a focal area of enhancement that's indicated by that curved arrow. And that might be, those features are consistent with hemorrhagic infarct and also parenchymal involvement. And then there's also a partial thrombosis of that right internal carotid artery, which you can see with the other little white arrow in picture B. If we move on to picture C, that's a post-coronal CT in a different patient, and you can see very subtle left epidural thickening along the floor of the middle cranial fossa. And then the last image is an axial non-contrasted CT, and that shows soft tissue infiltration of the right sphenotoin-palatine foramen and pterygopalatine fossa with the black arrowhead, and then with some extension into that right orbital apex, which is demonstrated by the white little arrowhead. So when we talk about the management, the mainstay of management really is trying to reverse that underlying immunosuppressive cause. This could be ketosis or, if possible, even your neutropenia. You have to have surgical debridement, at the very least endoscopic debridement, and you have to initiate broad spectrum antifungals. It's very important to manage that hyperglycemia with very tight glucose control. And studies have shown that if you are able to reverse the neutropenia, it actually improves survival. And in this regard, they do talk about whether or not there's a role of granulocyte colony stimulating factor to address the neutropenia. Surgical debridement can either be endoscopic or open. Endoscopic resections, according to one review, had significantly improved survival versus open surgery. But these patients that were undergoing open surgery also had far more advanced disease. For surgical debridement, it's really to do 2 things. You have to try and confirm the diagnosis, and you want to obtain a tissue culture. By debriding, it actually slows the progression of disease, and that may allow some bone marrow recovery in some patients. It helps you to remove that necrotic tissue, and you really want to debride until clear, until you have bleeding margins that are obtained. Often, your surgical debridement is determined by the imaging that you have, and also the tissue appearance at the time of surgery. And as in our patients, you often need multiple debridements. So you need to be aggressive early on, even though the extent of surgical debridement is slightly more conservative these days versus previously when it was a lot more extensive. There's very little consensus regarding orbital exenteration, and orbital exenteration is really only reserved for patients with a completely non-functioning eye. There's also very little evidence that radical resection improves survival, and that includes orbital exenteration and radical maxillectomy. It's very important to have a multidisciplinary approach in these patients. We involved ophthalmology, neurosurgery if there's intracranial extent, maxillofacial, infectious diseases, and also endocrine team inputs. With regards to antifungals, you want to start a broad spectrum of antifungal agent prior to identification of what the organism is. In other words, as soon as you suspect that this might be invasive fungal rhinosinusitis, and you must send off a culture in order to be able to determine sensitivity to the particular agent that you've actually started the patient on. Most commonly, as in our setting, we use Ampho-B. This is very effective for mucor and Aspergillus. This is really the mainstay of therapy, and you'll always initiate this even prior to the identification of the fungus. Dosage is at around about 1 kilogram per day, but there's quite a risk of nephrotoxicity. And because of this, there have been development of other Ampho-B lipid complexes and liposomal amphotericin B. These are a lot more expensive, but they are less nephrotoxic, and you can actually use them at higher concentrations for a lot longer. Many of these patients may require months of treatment, as an outpatient who was in hospital for more than a month. So once mucormycosis is excluded on your culture, you can then actually consider changing to a less toxic drug that is more effective against your Aspergillus species. So it's more effective against Aspergillus, but less reliable against mucor once you've excluded mucor. Invasive aspergillosis, you can use voriconazole. There have been studies that show increased survival and fewer side effects versus amphotericin B. And that's sort of a recommended dosage if you're going to use voriconazole. There are other alternatives like posaconazole, and this allows you to step down to oral treatment once clinical improvement is seen, and it is useful for long-term treatments. They also mentioned caspofungin. This is an option in your neutropenic adult patients that have very invasive aspergillosis whose disease is refractory to other antifungal agents. And then there is a mention of hyperbaric oxygen therapy, which has been proposed, but there's no clear evidence for that. Prognosis, well, our diabetic patients seem to do better, despite often having a lot more aggressive disease. This might be due to the fact that the underlying condition is actually more easily reversed than other causes, such as neutropenia. Patients with intracranial involvement have poor prognoses. Patients that don't receive surgery as part of their management have poor prognoses. Fortunately for us, Mr. S is doing very well. He's fairly happy with his outcome, and his vision actually improved to finger counting. And we will actually continue to follow him up as an outpatient. So the take-home message is, one, we have to have a high index of suspicion with immunocompromised patients. Treat them with antifungal therapy as soon as you suspect mucor, rather than waiting for a culture. Surgical debridement is very important, and you have to try to address the immunosuppressive condition as far as possible. Thanks.
Thank you very much, Louisa, for a very informative case presentation. Unfortunately, Professor Libbe has to present at another simultaneous meeting at the moment, but fortunately we've got one of her previous fellows from Ghana, Kafui Siro. I'd just like to invite him to comment. I know he successfully managed 1 or 2 patients in his time here last year. Mr. Al comes to mind. Kafui, any comments?
I think that's a very good presentation, and thank you for the update on it. So having been back also for close to a year now, we've seen about 5 of these cases also here. But for the fact that I had seen it over in Cape Town, I'm sure that would have been quite a tricky one there. So fungal sinusitis, especially with the mucormycosis, I think it comes from a lot of experience. The very first time we saw one, it was Prof. Luba who actually alerted us that this one was not a case to sit on. And ever since, we have the eye now. And one thing I must say is that whenever we are looking at the scan, the fast stranding is what I've seen plays a very significant role in letting us know exactly whether it's bacterial or it's actually fungal. So if we are looking at scans for complicated rhinosinusitis, I think we should spend much more time in looking out for all these details than just a cursory look. Thank you.
Thank you very much, Kafui. Prof, Lib, are you still there?
Yeah, I've connected to my car, so if you can hear me. So sorry, I missed what Kafui was saying there, but I just wanted to, with regards to the mucormycosis, I think, and it might be a little bit anecdotally, I mean, Nick is going to present or publish 3 cases of our recent cases, and what we found is that, you know, there really is a place for being less aggressive surgically. You know, in the past, when I was a registrar, we used to eviscerate eyes, you know, do really complete maxillectomy and quite disfiguring surgery for these patients, you know, in the belief that that's the only thing that will allow them to survive. But this case that Louisa presented now shows us that you really can get away with doing a little bit less destructive surgery, but keeping on top of it, taking the patient back to theatre every couple of days and just evaluating. And what we found in this patient, there was actually no advancement in the kind of the progression of the mucormycosis. And where we left some denuded bone, we had to keep on going, taking a little bit of necrotic bone away. But in this case, we managed to, you know, prevent a big oronasal fistula, which I think would have been very difficult to repair and would have required probably a flap to repair that. So just to know that you can be a little bit less aggressive, but stay on top of it and watch the patients carefully.
Thank you very much, Prof. Libbe. Professor Fagan, would you like to make any comments? Have you also noticed this evolution in terms of the degree of aggression surgically over your time?
Yes, most certainly. I remember when I was a registrar, which is a long time ago, surgery was very aggressive, and eyes were removed for what we now can manage endoscopically. It might be worthwhile also asking Mohammed Manasara from Nigeria to comment, because he's got a special interest in endoscopic sinus surgery. Mohammed, do you want to comment?
Okay. Thank you very much, Prof. We actually see a lot of fungal sinusitis, ranging from invasive to non-invasive. Recently, I managed a patient who has almost like automaxillectomy from the fungal sinusitis with proptosis. In that case, I have to do a lot of debridement, and he also has oroantral fistula. So I repair the oroantral fistula using the buccinator flap to actually close and I follow up the patient with regular debridement of the sinuses. And he comes regularly to, we check the sinuses with endoscope in the clinic, and he did very well. There's one we did actually who has also an excessive fungal sinusitis with erosion of the floor of the orbit. So in that, we did an external approach, and we have to reconstruct the floor of the orbit with a mesh in that case. But in that one, he doesn't have oroantral fistula. So in the patient that had oroantral fistula, he has like automaxillectomy. He has lost the fungal sinusitis, has eroded all the bony lesion in that site. So, and he has oroantral fistula that we have to reconstruct with a buccinator flap. So the challenges we have here is the cost of the antifungal, especially the systemic antifungal. Most of these patients that come are very poor and they don't have insurance cover here in Nigeria. Thank you, Prof.
Thank you very much, Dr. Manasara. I'd just like to encourage anyone, if there are any questions, to please raise your hand or post them on the chat function. I see Dr. Essa is also participating today. I know they see quite a lot of complicated sinusitis as well as fungal disease up in Natal. Any comments from your side, Dr. Essa? Okay, we seem to have lost Dr. Essa. I see there we do have some colleagues who are joining us from Frere. Any experiences from your side in East London? Okay, great. Professor Fagan, would you like to make any closing comments?
But just to, I think just to compliment both speakers, I think they were very good presentations today, and as a good discussion, and also to have all the comments from Darlene Nibber, who really is an expert in this field. Thank you very much for a very good session.
Thank you very much to everyone. And again, just to reiterate, if anyone from any other countries or any of our other provinces or institutions would like to present any future case presentations, please contact one of us, either myself, Gerrit Viljoen, Nick Gonsalves, or Tasia Din. Thank you very, very much, everyone, for today, and we will see you next week, Wednesday.